My name is Alistair Atkinson and I'm delighted to welcome you to this education event, which I trust will offer you a real insight into the benefits that the DySIS colposcope can offer. Today we've got the very kind participation of 3 clinical groups, 1 from the UK and 2 from the United States. From the UK we have 3 clinicians representing the Northern Gynecologic Oncology Centre in Gateshead, and they are Mr. Raj Naik, who is the clinical director there, Dr. Anne Fisher, who is a consultant gynecologist, and Dr. Christina Founter, gynecology oncology clinical researcher. We're actually especially fortunate to have Dr. Founter presenting today because last week she was given an award for the best presentation at the BSCCCP conference on the subject of her research into the DySIS colposcope. We'll then switch to the other side of the Atlantic to show how DySIS is contributing in 2 US private practices. We have Dr. Chris Olson, who's the President and Managing Partner at the Women's Center for Health in Naperville, Illinois, and Dr. Richard Salter, who's the President and Managing Partner at Advanced OBGYN Associates in Richardson, Texas. The agenda that we're going to cover today is roughly the following. After a brief overview from me about the unique capabilities of DySIS, Mr. Knight will provide some background to the Queen Elizabeth Hospital and in particular the use of DySIS within the NGOC. Dr. Fisher will then present her perspective on the impact of DySIS around quality assurance, documentation and medico-legal subjects. Dr. Founter will then present her results of clinical research and some case studies, and then we move swiftly across the Atlantic to Dr. Chris Olson and Dr. Richard Salter, who will share their experiences of using DySIS in US private practice. At the end of the presentations, we'll have the opportunity to ask the experts questions, and you can submit questions through your GoToMeeting control box, which should have appeared when you logged in. So by way of a brief reminder about DySIS, it is a colposcope, but with a very special and unique adjunctive feature. DySIS provides all the features that you would expect from a standard colposcope to properly visualize the cervix. Not only does it provide you with a very high resolution image, but of course you can magnify and apply green or blue filters and capture photographs. Secondly, while you perform the normal colposcopic evaluation, DySIS is measuring and quantifying the aceto-whitening effect and produces the unique DySIS map which you can incorporate with your other observations of vessels and margins. Finally, DySIS helps to standardize the colposcopic exam, not only through DySIS map measurements, but also through the comprehensive documentation set that is automatically generated and stored. Here is an example of DySIS map. As you can see, it is intuitive to read with the bright colors being used to highlight areas of intense aceto-whitening. DySIS map is therefore an additional piece of very valuable information to incorporate into your normal colposcopic observations of vessel margins and your own assessment of the aceto-whitening. In doing so, it standardizes much of the colposcopic exam. It provides first-rate documentation of the exam, which in turn facilitates longitudinal tracking and conservative management. Before moving to the main event, I'm required to read the following regulatory disclaimer relevant for the US audience. DySIS Advanced Cervical Imaging System is FDA cleared as substantially equivalent to a colposcope with an adjunctive imaging map. The following information is meant to be educational only, including the experience of the UK teaching hospital, and may contain claims of superiority that are not within the FDA cleared labeling. I'm now going to hand over to Mr. Naik, Clinical Director at the NGOC, who will give an overview of the DySIS program in his facility.
Thank you, Alistair. Good afternoon, everyone who's here from the UK, and for our US delegates, good morning, and those from the East, good evening. My task today will be to provide an overview of the Queen Elizabeth Hospital in our department, which is the Northern Gynecologic Oncology Centre, and we are a long-standing department with a strong tradition in research and training and surgical innovation, mostly in gynecologic oncology but also in colposcopy. For that reason, we developed an interest in DySIS, which we felt from some of the preliminary data that was released a few years ago to be a major breakthrough in terms of improving the sensitivity and outcomes in patients undergoing colposcopy. From there, we appointed Christina and began some of our research projects, which Christina will present, and Anne Fisher, who's leading our colposcopy service, then implemented the DySIS machine into our department. From there, we became the first workshop training centre for the UK, and we have a strong tradition in training, in that we also run open cadaver surgical courses, laparoscopic cadaver courses, live surgical courses. So running the workshops from here in Gateshead seemed fairly acceptable in terms of our standard practice. Our main interest in DySIS really were that it provides superior outcomes in terms of patient management, but also in terms of cost effectiveness. NICE, which is a regulatory body in the UK, reviewed our data from our department and showed that the instrument and the technique is cost effective. So really on that point, it seems sensible that we promote what we believe to be a major advance in colposcopy through webinars and workshops, but also through research and training. So thank you all for connecting today, and I hope you find the next few moments fairly informative. Thank you.
Right, we'll go on to me next, if that's okay. I'm Anne Fisher, and I'm a colposcopist and a gynae oncologist. I lead the service here at the Queen Elizabeth Hospital. And I'm going to talk a little bit about quality assurance and actually how it is that we use a DySIS in our everyday practice. Quality assurance is really important. In the UK, our practice is very highly regulated. All our referrals come from cases referred to us within the National Screening Programme, and it's regulated by Public Health England. All our practice as colposcopists and of our clinic is actually audited as part of the BSCCP, which is the Society really of Colposcopists and Cytopathologists. And that's where Christina's recently been awarded a prize for doing the best presentation all about DySIS. So well done again, Christina. We're getting it in for you there. Okay, so we get direct referrals to colposcopy, and all our management is quite guideline and protocol driven. So we're very keen that any additional equipment that we use adds to what we do already and improves the service that we have. So if you flick onto the next slide there for me, Kim, we'll have a look at that. Could we do them? Oh, great. So what we find with colposcopy is there's a lot of subjectivity. What we're really keen on doing is diagnosing and treating high-grade lesions, and we'd be very keen on safely discharging patients who don't require treatment. So looking to things which can personalize a treatment for the patients that we look after. Within the BSCCP, within the last few years, we have some new categories of cytology results which have come out, most particularly those people who've had treatment in the UK for high-grade change now get a cytology specimen 6 months later, which includes HPV tests. So we get this new category of cytology specimen called test of cure. Christina's going to give us a lot more information on that now and show how it is that DySIS is so very useful in this category. For those people with a low-grade cytology, we're really keen on being able to pick out the cases who really have high-grade change, and that's where the objective adjunct, the DySIS colposcope, is very helpful to us. We know that the agreement between colposcopists is really poor. We find difficulty differentiating low and high-grade lesions, and as fabulous as we all think that we are, actually the DySIS is superior and consistently so. We're very keen on preventing unnecessary biopsies in our women and on looking to biopsy the right area, and that's where the DySIS is so very helpful. So if you go on to the next slide for us, that'd be very helpful. So what information is there? Well, there is approval for this technology use within the UK from documents from the NHS cervical screening program, approving the use of the DySIS machine and providing the evidence to show how the adjunctive colposcopy technology for the examination of the DySIS is beneficial, and that's some of the things that Raj had alluded to from information that came from our centre. And this is hot off the press. The BSCCP and the NHS CSP publication, document 20, that's really the Bible for all colposcopists here. That's what we refer to in our practice, and for the first time adjunctive colposcopic technology has been mentioned in there, and the DySIS certainly has a recommendation within that document, and that's new. That's within the last month that this document's come out. So there's more and more saying information out there for colposcopists in general. So if you go on to the next one, please. Documentation, generally colposcopy has, as I said, a lot of subjectivity associated with it. You'll all have your individual systems of how you document things, and really it does rely on the same colposcopists time after time assessing those longitudinal cases. If you go into the next half of that slide, DySIS is objective. You can save the image. You can readily use these, and we do in our clinical practice. We can, very handy for longitudinal record keeping. The information can be securely stored, and particularly for complex cases, which we discuss at multidisciplinary meeting. Those are our normal diagrams on the left. Is that one of mine or one of yours, Christina? I'm not sure. That's our standard. And if you flick onto the right, we can see the advantages immediately and visually of what the advantages are there. So that's very helpful for our complex cases in particular. So if you'd like to go into the last slide, in summary, there's a lot of evidence for use of DySIS. It's BSCCP recommended. It's NICE approved. It's an objective adjunct which is effective both clinically and cost-wise. Quality assurance is great. It's fabulous for training. We do a lot of training here. From a personal development point of view, it adds a little bit of excitement into colposcopy clinics, and we feel that it adds value to our current practice. So thank you very much, everybody, and I'd like to hand you on to Christina.
Thank you, Anne. Hello, everybody from me. I'm Christina Fount, and as you can see, I come very highly recommended today, so I hope I can be up to that. I would like to make it clear that this has all been teamwork, and I would like to thank everybody who has been helping me through this, and especially Mr. Asnaik, my supervisor, who has been behind all this, and this was actually all his idea. So what I'm going to be presenting to you in the next few minutes is the research results from our projects, and as it has been already touched by Anne, in the NHS cervical screening program we do receive very specific referrals in our colposcopy clinics, and we have recently implemented some changes, and we now perform reflex high-risk HPV testing for certain groups of women, and those two groups are low-grade screening smears and negative and low-grade smears for women who had treatment for CIN, and this is called test of cure. Next please, Kim. So if that HPV test is negative, then people are discharged, women are discharged back to routine recall, and if it's positive, then they come to colposcopy clinic, and from colposcopy clinic we need to decide what the further management is going to be. And these results, these implementations followed the results of the Sydney SIDE study, which was a large multicentric UK-based study, and it showed that performing HPV testing for this group of patients is both cost-effective and it is safe. So in the NGOC, we have been using DySIS since February 2013, and up to now we have seen more than 600 patients and examined them with DySIS, and this number refers to all referral groups. And what we're trying to do is audit our results in specific patient groups, and we aim to assess the accuracy of DySIS in these specific patient groups and see if that can improve our clinical management. Next, please. So the first group I'm going to present your results on is the test of cure group, and actually is the group that we have so far done most of the analysis on, so we have most of the results on. For this group, what we do now, according to the NHS cervical screening program, is that they come to clinic, and if colposcopy is negative, or if you perform biopsies and biopsies are negative, then what you are expected to do is discharge these patients back to 3 yearly smears. And we do know for this population that it's a very high-risk population, and the risk for cancer is almost 5 times higher than the rest of women, and that lasts for at least 20 years following their treatment. And additionally to that, it's a newly introduced group of patients. We don't have any long-term data available on the accuracy of colposcopy for this cohort, and we don't have data on the performance of DySIS on the scar-regenerated cervix after treatment. Next, please. So this study was a prospective observational study, and the results I'm going to present to you was the results we have in Gateshead from March 2013 until November 2014. The population included were all women referred to colposcopy with a negative cytology, high-risk HPV-positive sample after having had treatment for CAN. And we have two groups, the study group, in which we included all women that were examined with a DySIS colposcope, and the control group, in which we included all women that were seen with a conventional colposcope during the same period of time. We did follow everyday practice, and especially for the study group, the biopsy selection and the colposcopic impression before and after the DySIS map was apparent was noted and was logged on the system. And as primary outcome, we used histologically confirmed CAN disease. Next, please. So we have in our study group 105 patients, and in our control group 2,020 patients. And for both of them, we have collected basic demographics as well as information regarding their previous loop treatment. And those data were comparable between the two groups. Next, Kim, please. And next. And you can see in the graph that the age distribution was comparable between the two groups, like I said. And the next one. And the year since they had the loop treatment was comparable as well. If you click for me again, Kim, so what I want to make clear is that in both groups we have included the catch-up population as well, meaning women that had treatment in the past and they were still on yearly smears and they belong to the catch-up population. So actually in both our populations, in both our groups, the women that had their failed test of cure smear 6 months after treatment were only representing a percentage of about 20%. Next one, please. So in our study groups, you can see in this slide the results of the histology outcomes, and on the pie on the left, you can see the histology outcomes amongst patients who actually had histology performed. So amongst them, the high-grade disease was histologically confirmed in about 6% of them, and 31% of them had CAA1. Now, if we transfer these results to the whole of the study population, meaning the 105 women, then we can see that if I remember the numbers right, there was about 4.8% of CAN2 plus in the whole of the study population and 23% of CAN1. Now, again in the study group, amongst the 5 women that had histologically confirmed CAN2, colposcopy was high-grade for none of them, and the DySIS map indicated potential high-grade lesions for 4 out of 5 of them. Now, accepting these are very small numbers, if we go on and calculate sensitivity, specificity, negative and positive predictive value, we can see that actually the sensitivity of colposcopy is very, very low, and it improves significantly when the DySIS map is integrated. And then again, accepting that we cannot actually accurately calculate negative predictive value without having adequate follow-up. But if we use the histology of the punch biopsies to do that, and if we consider women with no histology as being negative, then the negative predictive value of the DySIS map in detecting CAN2 plus was 99%. Next one, please. So next thing we did was compare between the two groups, and you can see on the top of these slides the numbers we used to perform this comparison. We used Fisher's exact test to compare between the two groups, and what we found was that for the detection of CAN1 as well as the detection of for any degree of CAN, there was a statistically significant improvement in accuracy when the DySIS map was integrated, whilst for CAN2 plus lesions our numbers were too small to be able to reach statistical significance. Next, please. So to conclude about this group, I would like to show you this table where I've basically included the numbers from the Sentinel site study and our control and study group. So for our control and study group, I've only included in this table the women that had their failed test of cure smear 6 months post-treatment, so that the numbers can be comparable between them. So you can see that in our control group, the percentage of disease harvested, both low-grade and high-grade, histologically conferred, is actually much higher than the numbers in the Sentinel site study, and in our study group it's even higher. So this clearly indicates that there is disease missed. And for CAN2, there is a trend showing very low sensitivity for colposcopy, which improves a lot when the DySIS map is integrated. But for any degree of CAN, there is a statistically significant improvement in the detection with the implementation of the DySIS map. And the other point I would like to make is that if we look at the catch-up group, which actually represents the majority of our population, most of the disease was harvested in women with previous negative yearly cytology, and most of them had yearly negative smears for many years before they actually had their failed test of urine that were referred to clinic. So this could potentially raise questions about what should the follow-up be for this population, because we will still definitely miss some disease there. Shall we maybe consider performing HPV testing for these patients, for women that had treatment in the past, even for negative cytology? Next one, please. So the other group I would like to talk to you about is the low-grade high-risk HPV positive referrals. We haven't, even though we have had a lot of interest in that subgroup as well, for many reasons, like Anne mentioned, and I will say some things about it as well. We haven't yet performed analysis, the whole of our analysis on that, so I'm just going to present our pilot results. So this group represents a lot of challenges as well. It's usually are not the same exactly. They're not all of them HPV positive, and they are either of unknown HPV status or mixed HPV status. And what we also know about low-grade referrals from the ATLS study in the States is that if we try and use colposcopic characteristics to grade lesions, this lacks sensitivity. So if we try and do that to decide which site we're going to biopsy, then we're bound to miss disease. Next one, please. Right, so again, this is an ongoing observational study, and we are including all low-grade high-risk HPV positive referrals to our colposcopy clinic, and the objectives are to assess the accuracy of the DySIS map, but most importantly, the combined performance of the DySIS map and colposcopy together. And again, we are very interested in assessing the negative predictive value of the DySIS map when colposcopy is negative, because if that is found to be accurate enough, then maybe we can omit performing biopsies for patients with negative colposcopy and negative DySIS map. And also we want to see how good DySIS is in helping us decide where to biopsy from. Endpoint for this study was also CAN2+ histologically confirmed. So in 20 months period, we have included so far in this group 149 patients, and of those we have histology available for 119, and you can see in the pies the histology results. The one on the left refers to the women that had histology performed, and the one in the right, the ones, the whole of the population, the 149 women. Next one, please. And then again, we calculated sensitivity, specificity, negative and positive predictive value, and you can see that the colposcopic impression sensitivity is very, very low. And this is something that persistently comes on to different studies, and this is because, as we all know, when you examine someone in colposcopy with a low-grade smear, you're a bit biased towards calling the colposcopy low-grade as well, whilst the DySIS map is much more objective. So that's probably the main reason why it looks like the combined prediction, when you combine the two of them together, the accuracy of that is much higher. So the accuracy of that is 76%. And again, with the same limitation in calculating negative predictive value, like I mentioned before for the previous group of patients, the negative predictive value of the combined negative predictive value of the DySIS map and the colposcopy for detecting CAN2+ for this population is at the moment 83%. Next one, please. So to conclude, for low-grade referrals, it looks like there is similar sensitivity, combined sensitivity to the previous studies which were performed for patients with unknown HPV status. And we feel like we still need to assess the negative predictive value. Now, for the future, of course, we need larger numbers to be able to draw safe conclusions for patient groups of high clinical interest. And another thing we're thinking about is to use DySIS to standardize care between different centers. And regarding the high-grade referrals group, our thought about analyzing our results and our data on them is mainly to see, we think it would be of great value to try and see if DySIS can assist in reducing over-treatment for these patients, as in choosing between see and treat and select and treat, especially for young patients. Next, please. So I'm going to present to you now some case studies which we think are are representative and have some high interest. Yes, Kim? And the first patient I'm going to present to you belongs to the low-grade dyskaryosis group. So this is a 37-year-old patient, para 5, who is a smoker and uses no contraception and had no symptoms or comorbidities. She was referred with a borderline high-risk HPV positive smear to our clinic, and this is the cervix before the application of acetic acid. Yes, next one please. This is the cervix after the application of acetic acid, and if you click the next one, Kim, thank you. This was considered low-grade by the colposcopist who examined this patient, and this is the map, and you can see that there is an area of possible high-grade disease indicated. So I don't know if you can see this, but there is like a little circle with a cross there, which means that we selected this area to biopsy it. Next, please. So the biopsy of that showed CIN2, and we went on to perform a loop biopsy for this patient, which showed CIN2 again completely excised, and she had her follow-up, her test of Q cytology, which was negative, high-risk HPV negative, therefore she's now discharged to three yearly recall. The next patient belongs to the high-grade dyskaryosis group, so she was a 25-year-old patient, para 1, non-smoker, using the compliant oral contraceptive pill, and had no symptoms and no comorbidities. This was her first smear, and it was a severe dyskaryotic one. So this was the cervix as it looked before the application of acetic acid. Next, please. And this was after the application of acetic acid, and I think it's quite clear that you can see the density of white epithelium, the mosaic, and this looks like colposcopically like high-grade disease. Next one, please. Next. And this is the map, and you can see how typical it is, how the way the DySIS map shows the high-grade disease. So all this white area and represents the high-grade area on the DySIS map. Next one, please. So this patient, we went on to perform a loop biopsy for her. She was treated as see and treat, and the histology of the biopsy showed CIN3 involving ectocervical and left lateral margin. She had her follow-up cytology in May 2014, which was negative, high-risk HPV negative. So again, she is discharged to 3 yearly recall. Next, please. This again is a patient who was referred with a highly dyskaryotic smear. She was a 31-year-old patient, para 2, a non-smoker, and she was using the progesterone implant for contraception, no symptoms, no comorbidities. She was referred with a high-grade severely dyskaryotic smear. Next, please. So this was the cervix before the acetic acid. Next. And this is the cervix after. Next, please. And this was considered high-grade colposcopy. You can see here a little bit more inside the canal. Next, please. And this is the map, and you can see how it picks up the high-grade lesions area. Next, please. So again, we performed a loop biopsy for her, which showed CIN3 completely excised, and she had a follow-up cytology in April 14, but HPV was unavailable when she had that sample taken, so she had another one in October 2014, which was HPV negative, and she was discharged as well. Next one, please. This is a lady from the test of cure group, so a 23-year-old, para 1, a smoker. using implant for contraception, no symptoms from comorbidities. She had IBS, depression, and headache, and she was referred in 2013 with a borderline high risk HIV positive smear, having had a loop biopsy in 2008 for CAN2. Next one, please. So this was the cervix before the application of acetic acid. Next. And this is the cervix after. And you can see the scarred epithelium of the ectocervix where she had her previous loop. Next one. So this colposcopy was considered as showing HPV changes only by the colposcopists who saw her in clinic. And this was the map. So it was decided to perform a biopsy from, I don't know if you can see the area, there is a purple circle there with a cross as well in the middle. So we biopsied that area. Next one, please. And the punch biopsy showed CAN3. So she had a loop biopsy performed, which showed CAN2 completely excised. And the follow-up cytology again was negative, high-risk HPV negative, and again she was discharged to 3-year smears. Next one, please. So this is the last case, and it belongs to the follow-up group. And it's a 28-year-old patient who's paranoid, non-smoker, no contraception, no symptoms. And there was male factor infertility, due to which she was due to commence IVF treatment, and she was cancelled about cervical stenosis and potential future prematurity in pregnancies if she went on to have a loop biopsy. She was referred to us with a moderate dyskaryotic smear, high-grade smear, in 2013. So this was the cervix before the application of acetic acid. And this was after the application of acetic acid, and colposcopic impression for this was low grade. Yes, next one, please. So this was the map, and you can see it shows areas of potential high-grade lesions. So the colposcopist performed 3 different biopsies that were all selected after the map was apparent, and you can see the different sites. And they were all noted and sent to the lab separately. So site 1 showed CAN1 and sites 2 and 3 showed CAN2 disease. So the patient came back to clinic and she was examined again, and this was the cervix before the application. This was 3 weeks later, 3 weeks after the last time she was examined. This is the cervix after the application of acetic acid, and again colposcopic impression was low grade. Next, please. Next one. So this is the map, and you can see that the map is at the most low grade now, marginally low grade, I would say, and you can see that the areas that were previously highlighted as high grade in the map are the ones that were most likely removed when she had her punch biopsies performed. So they are not picked up now. Next one, please. Even though she was cancelled strongly against having a loop biopsy, we need to offer it to her since she had punch biopsy showing CAN2. And the patient had very strong feelings towards having a loop biopsy so that she could put this behind and go on and have her IVF treatment. So she had it, and the histology showed CAN1 only and HPV changes. The follow-up cytology is not still performed because the patient is trying for pregnancy, and a detailed letter was sent to fertility clinic regarding all what should be done for her in the future regarding her future pregnancy. So that was us. Thank you very much for your attention. And I would like to now introduce Dr. Chris Olson from the States. Dr. Olson.
Thank you, Dr. Fanta. That was very helpful. Thank you very much. And that was a quick jump across the pond. I'm in the western suburbs of Chicago. Next slide, please. I'm in private practice. We are a single specialty group with OBGYN physicians as well as nurse practitioners, and adopted early on a wide range of in-office minimally invasive procedures, both to be consistent with where healthcare is going in the States, and also always interested in new technologies. That led me to explore Assure hysteroscopically in the office. We do office-based ablations as well with several different technologies, and now the DySIS system has been brought into our office, and we're only early on in our experience, but really enjoy it for a lot of the reasons mentioned before. As we've all known, even in the United States, even in the most elitist of hands, trying to get some consistency between other colposcopists is difficult. And anywhere from 20 to 60% of the time, there's different interobservable differences between different colposcopic examiners, and this allows us to have more consistency across our entire group. We certainly don't always agree on which areas to biopsy, and management styles for low-grade lesions are certainly different than those for high-grade lesions. So that allows us to do our own internal sort of practice quality standardization. We now have maps that will show us what we saw. It allows others to review what we've seen. There builds in some consistency. I think most importantly, it's caused me to slow down a bit. It allows for at least a full 2 minutes of evaluation for the map to create itself. And because this is a kinetic process as well as an intensity, it allows for a more thorough evaluation of the cervix. And I think that intensity is as critical as you saw in a couple of previous examples and as you're going to see in one of our examples. It's reliably documented, so in the land of lawyers or Lincoln here in Illinois, it certainly helps protect us medical legally and shows us exactly what we've seen on each exam. Our first example is a 49-year-old white female, gravida 3, using birth control pills for contraception. Essentially, she's had multiple normal negative pap smears with us through 2011. She developed an abnormal pap in 2012, showing low-grade changes, and traditional colpo biopsies confirmed mild dysplasia, and we simply followed her. Next year, she has a pap with ascus changes with no HPV. We're less interested there. We're assuming that she's healing or suppressing the virus that she was exposed to. In July of 2014, now she's positive for either a new one or a recurrence of her high-risk HPV. And at this point, we now had a DySIS colposcope, so it allows us to examine the cervix, essentially a benign appearance of the cervix. However, when we threw color on it, measuring both intensity and the duration that the cells express the acetic acid, we discovered a severe lesion, which led us to perform a LEAP and cure her. Next slide shows the reference image, a little out of focus. The right side is showing the end of the acetocyte process, and it's showing some minimal changes there along the squamous columnar junction, but nothing to get all excited about. We certainly would perform a canal sample. I don't want to give you the impression by this slide that we took all these biopsies. This is early on in our experience when we were being taught how to place where the biopsies go. We took one biopsy on this patient at the 4 position and couldn't figure out how to undo this. But at any rate, you can see the pseudocolor map on the right, which shows some lighter areas of intensity, and that's telling us that this part is the most worrisome. If you look on the left, there's actually some aceto-white just adjacent to that number 4 biopsy site. But the DySIS map is encouraging us to look there on the edge. So we took a biopsy of that site. It showed severe dysplasia and certainly was an eye-opener for us. This is either the first or second patient that we saw on DySIS, so we certainly got our attention right away. Second example is a 34-year-old white female, gravida 4, period 2022, using condoms for contraception, and she simply had a low-grade pap. We performed the colposcopy with the benefit of DySIS, and this is an example of where there's a diffuse area of aceto-white changes, but very difficult to tell with routine colposcopy which area is most concerning. The DySIS map helped us direct our biopsy within the aceto-white change and found moderate dysplasia confirmed on the LEAP specimen. So the reference range is there in the beginning, the acetic acid to the right, and you can really see the DySIS map light up in the more worrisome aspects of that. Not sure I would have necessarily chosen that area to biopsy prior to the map, but it directed my biopsies there. We took them there. That was the sweet spot, and didn't delay in any treatment. So again, this is showing the most worrisome parts of an aceto-white area. The first example was showing the areas that I probably wouldn't have biopsied before. and it allows us to not delay in the treatment of someone who actually had more intense disease. And we have several examples where we biopsied somebody that had mild dysplasia and we chose to follow her only to find out 1 or 2 years later we biopsied a different spot and got more intense lesions. So it's either a progression of the disease or missed on initial evaluation. So this allows us more timely evaluations for the more concerning ones and the more conservative treatments for the less concerning ones. Unique value propositions in our practice, certainly as the Chicagoland gets more and more crowded and intense with physicians, it's always nice to have some unique factor within our practice. Brochures and websites have allowed excellent training and education of our patients. It reinforces the new pap smear guidelines in the U.S., which has certainly been a little shock for our patients to space out their pap smears every 3 to 5 years. We're assuring them that we now have a higher tech evaluation and a less subjective evaluation of the pap has certainly made them a lot more comfortable. It hits the high-grade lesions like we'd like, and it is also cost-effective. The highly calibrated light source being polarized helps reduce glare. You can list here all of the advantages that you don't have over a traditional colposcopy, both intensity, the standardized imaging, video loop playbacks, documentation, high contrast filters, all these lead to just a wonderful addition to our evaluation of abnormal pap smears. I'm going to turn it over to Dr. Salter.
Thank you, Chris. I want to tell all of y'all howdy from Texas. We have been using the DySIS now for approximately 6 months, and my practice is we have 4 OB-GYNs, and we also have a physician's assistant. We try to differentiate ourselves by innovating the leading technology to assure quality patient care for all of our patients while still trying to maintain it in a personal nature. I try to be an early adopter, as do my partners, for new technology once we have evaluated it and found it to be giving the results that the manufacturers do claim. I've been a Da Vinci instructor and proctor for about 7 years now. We incorporate several different ablative techniques in our office: her option, cryoablation, ThermoChoice, NovaSure, and hydrothermal ablation. We've been doing Assure's hysteroscopic sterilization in our office now for about 7 years. We do mini-arc TVTs for incontinence in our surgery centers, and now we've added the DySIS system to our armamentarium of treatments for women. Next slide, please. The case I'd like to present is a 21-year-old single female. She has no children, non-smoker, been sexually active, history of 7 different partners starting at the age of 14. She intermittently uses condoms, no birth control pills, or any other form of contraception. This was her first abnormal pap. She's had 2 previous normal paps. The last one was approximately 4 years ago. The results of the pap smear that I did showed a low-grade SIL with high-risk HPV. A little bit less than a month later, we did the DySIS Colpo. We did several biopsies. The first 2 biopsies showed moderate dysplasia. The second 2 showed severe dysplasia, and I'll show you those on the mapping here in just a second. We then proceeded to do the LEAP, and I have started incorporating DySIS with my LEAPs, and I found that it's been very beneficial both for myself, my partners, and for the patients. And I'll go over those benefits in just a second. Here you see the slides, the reference image before the acetyl white application, the slide on the right after we apply the acetyl white. Not very remarkable. You see a few abnormalities, but nothing that really jumps off the map at you. The third slide there on the left does show you the biopsy sites that we picked. The first and second one were done before the mapping, and then the third and fourth sites were done after the mapping. Then on the mapping side, you can see how if I had not used the mapping, I probably would have missed the most severe areas by using traditional colposcopy. The biopsies on the right did show that we had CIN3. We went ahead and did a LEAP, and it did confirm there was CIN3. We had negative margins both on the endocervical and on the extracervical. And the nice thing about using this was that the patient could see how the margins were, exactly what we were going to remove. It allows us to be able to compare colposcopies from the same patient from different appointments so that you can see the advancement if there is some or if it is regressing, as well as show the patient this. The video feature on the DySIS allows us to videotape the leap and verify that the bleeding has stopped at the completion of the procedure. It also allows you to see exactly what tissue was removed. And finally, by being able to compare the colposcopies after the leaps, you'll be able to see if you are truly getting all the abnormalities that you see while doing the procedure. Several tips that may sound intuitive to some, but I find that I just have to constantly remind myself to do these to optimize the use of the DySIS, is to make sure the DySIS is in focus. I think Chris mentioned to you on his slide, he had one that was slightly out of focus. That does tend to help both with your perception of the abnormalities as well as the computer-generated map. We obviously use a coated speculum to prevent any kind of patient injury to the vaginal walls. We give the acetic acid plenty of time, the 130 seconds, to facilitate the acetyl white changes and also allow the computer software to map the abnormality. One thing that we have found is that we really have to stress to the patient, try to remain still. A lot of times the legs will fatigue and you'll get a little bit of shaking, and if the shaking and the movement is too much, then the computer will not be able to map the cervix. We try to make sure that we get about a 3 to 5 millimeter margin outside the area to assure complete removal of the abnormality on the ectocervix. And we try to keep our specimens 8 to 10 millimeters, so very thin when we do the leap. That way we don't have to worry about cervical incontinence with subsequent pregnancies. Next slide. From a marketing aspect, I really feel that this is the next step in allowing the patient to be able to see what we're doing and also to help us. We use the monitor to explain the abnormality to the patient and let them be more involved with their care and their treatment. And this gives them a sense of calm a lot of times when they don't feel like they're outsiders just having these procedures done to them. So I've had a lot of patients refer me to friends of theirs with abnormalities simply because they felt so comfortable after going through the process with them and then being able to actually see what's being done to them. I've worked with my local DySIS rep, and we've set up peer-to-peer lunches and dinners with referring physicians to make them aware of this technology, make them see the advantages of this, and to differentiate our practice from other practices in our locale that don't incorporate the DySIS technology. I've made every offer to speak at different women's groups, luncheons, and dinners, such as the Junior League, Teachers Association, health fairs, and hospital open houses, to get the word out about the new technology we have in the treatment for abnormal pap smears, as well as our own practice. Another thing that you can do is contact your local TV, radio, and print media. Let them know about these new advances. These health care reporters are constantly looking for news stories, and I've had this use very successful with other technology that we've incorporated into our practice. And finally, when we send out our annual exam reminders and cards for abnormal pap smears, we've already printed the information on our cards about the DySIS website, and it allows the patient to go ahead and look at this information, and therefore when she comes in to talk to us about it, she already has a basic understanding of it, so it's not something that's so foreign to her that she feels uncomfortable with it, and she already has a lot of questions that she would like answered, and it makes it a lot easier for us.
Well, thank you very much indeed to all of the panelists. We do want to open it up to questions now. I can say at this stage that nobody has submitted a question to the panel. So I would encourage anybody in the audience who's got a question burning in their mind just to type it into the question box and submit it, and then we can put it to the panel and discuss it. Perhaps while that's going on, let me just pick up on the last points that Dr. Salter made and perhaps ask the other panelists about the patient reaction that they've had to DySIS. Perhaps we can go to you first, Mr. Mike, and the NGOC team.
Okay, I think the feedback's been very positive. Christina and Anne do most of the DySIS colposcopies in our department, so they'll probably know better from an immediate point of view. But certainly my experience from various patients is that, as has been presented already, I think patients like to be able to visualize what's being done. I think they like the technology from the fact that it is objective. I think when the data is presented to them from the point of view of the improved sensitivity and therefore aftercare, but also the opportunity to be more conservative, I think they're all seen as positive assets and clearly an advance to what's otherwise described as established practice. Christina, what would you say?
I agree. I don't think I have anything to add, especially if you explain to patients that there is advantages, and they understand that, they appreciate that a lot, and for specific patient groups there's clear advantages. I don't think I have anything else to add.
I would agree with Chris and Richard, what both of you have said as well about empowering women, because it does really help people to be able to see those images themselves on the screen, give them an idea of what it is that we're looking for, what we're looking at, and it actually helps some women to make a choice about what they'd like to be done. So we can definitely tailor treatment much more effectively and give people the choice about what they'd like to have done. It's very positive. Particularly, I find playing the video back during the examination is very helpful, because people can actually watch the video play back out over time. I think, as you were saying, Chris, it makes you be a better colposcopist because you wait for the full 2 minutes. You guys are saying 130 seconds. In my experience, it's between 124 to 126 seconds. So I've got a little bit of chit-chat that I can have, and that includes playing the video back in that time, so I can fill up my 2 minutes in that time, yeah. It's really, really very helpful.
You know, amen to that. I mean, as a busy GYN surgeon, I have the attention span of a gnat, and this has really slowed me down and made sure that I do a thorough evaluation. And the other comment I have is that it's not just a video colposcope. I mean, there are a lot of video colposcopes out there that kind of present the entire vagina and the cervical area. This particular DySIS map just outlines the cervix. And so it's not, it has a less ooh-ick feel to it as patients are looking at their own cervix. And the color map is actually pretty, and it just tends to be just a different evaluation. We evaluated other straight colposcope videos, and patients did not want to see their cervix. This is definitely different. This definitely is a different experience for patients.
Alistair, if I could just finish off with one other additional point, that's the medical legal aspects of the advances of DySIS, in that it's clear that using standard colposcopy, some cases of high-grade sin will be missed. And as Christine has mentioned already, there's uncertainty with regards post-treatment management and whether test of cure perhaps also has a place for future aftercare rather than just immediately after the treatment. But clearly some patients will go on to develop cancer at some point or other. And the question, as the awareness of DySIS amongst the community and I think amongst the population becomes more clear, I think there'll be questions raised to why was a DySIS not used? Could this have been prevented or picked up earlier had a DySIS been used? And now that it is being supported by our national regulatory bodies, in particular NICE and the NHS ESP, I think those questions are going to become quite valid. It's going to become difficult for many of us that don't have DySIS to be able to provide a robust response.
Very good. Thank you all very much. Let me just pick up on one other point that I think was mentioned by everybody through there, and there were the terms conservative management and conservative treatment. Can I ask perhaps each of you to expand a little bit on those areas and how DySIS can assist? Dr. Salter?
Well, I think as far as allowing us to get the maximum amount of treatment for the patient with a minimum amount of invasiveness, I'm less likely now to jump to a leap if I have both documentation of the progression of the abnormality and can see exactly the margins of the abnormality. I may be wanting to watch the lesion just a little bit longer, give the body a chance to combat the virus and possibly even regress the lesion. So I think it allows us to be more conservative in our management, less tissue damage when we do have to do an invasive procedure, and allows for less complications after the procedure, say with incompetent cervix or premature labor and delivery.
Thank you. Dr. Olson, would you like to comment?
I completely agree. I think at first do no harm, and if these viruses are transient and they are suppressed in a high degree of consistent time, so 80 to 85% of the time you're going to suppress your HPV virus, it's prudent for us to be conservative with our younger patients, and having this additional arrow in the quiver does allow us to be conservative when it's appropriate.
Thank you. And NGOC team, any comments to the same?
If I can start, I think there's two groups. Firstly, I think we're becoming more conservative with the SIN2 cases as well. So I think rather than lump SIN2 with SIN3, I think many people, especially in young patients, are wanting to separate the SIN2 cases. So I think it's become more important now to try and consider conservative management of SIN2 cases, especially in young patients. And I think DySIS does help with that. Rather than have a see and treat policy, I think we are becoming much more select and treat with our high-grade cytology cases. I think the second group are those where they are complex cases themselves for various reasons. They get discussed at our mismatch meetings or correlation meetings or MDT meetings, whatever you want to call them. And it's easy to say, okay, do a loop or a leap to try and get histological evidence. But as with the reassurance of a negative HPV test, we're also now achieving similar reassurance with a negative DySIS test. And I think Anne is our colposcopy lead, so she'll know better. But as I say, I think I'd be interested to hear what Christina has to say as well.
I think the thing I'll say about DySIS, certainly from the figures that Christina has given us, we know that, and from the literature, is that it has probably an 88 to 90% specificity in detecting high-grade change. So we should always be aware that there is still that 10 to 12% of patients that DySIS can miss high-grade change in. So we'll always keep that in reserve when we're still looking at high-grade cytology, but having negative DySIS. So it doesn't necessarily mean we have to go in and discuss those patients, but those are exactly the group of patients that we will discuss at our meetings, because we want to make sure that we don't miss or overtreat patients. And certainly an area that we haven't looked at in detail, but clearly we have many cases on our books from the practice that we've had so far, and the group we need to look in more detail is those people who have high-grade change on their referral cytology, and actually looking in more detail as to how exactly is the DySIS helping us. And definitely our clinical practice has evolved over the few years that we've been using it. But again, that's something that we're in the process of auditing and keep re-auditing and having a look at to make sure that we're not becoming overly reassured by the technology we're using, and making sure that we review our practice. But I think that's really, it is really important, but it is helping us to personalize treatment for people.
Excellent. Thank you all again. We do have a couple of questions that have been submitted from the audience, from Dr. Carolyn Quist, one relating to the cost of the device, and all I'd say is, Dr. Quist, is you're in the Fort Worth area, I believe, and we'll have our representative come visit you if that's okay. The second question relates to really some technical questions about image retention, documentation, and so on. Dr. Quist asks, how long does it retain the mapping? If it's okay with the panel, I'll answer these technical questions. The maps are actually retained electronically as long as you wish. The device has about a capacity for around about 10,000 patient records to be retained on the instrument itself, but there's all the facilities that you need to export them and have them connected to your EMR system so that they can be retained on your EMR system as well as, or instead of, on the system. Dr. Quist also asked whether the maps can be viewed side by side, and the answer to that, Dr. Quist, is yes, they can. We have a function called compare mode that allows you to pull up two separate exams. Not only can you compare the maps side by side, but you can replay the entire video of both exams side by side. So I hope that answers your questions. There are no more questions submitted into the box and nothing else coming up on the chat, and we're pretty much up against the end of our time. So it just remains for me to say thank you very much indeed, not only to the audience for attending, but especially to our panelists, Mr. Raj Naik, Dr. Anne Fisher, Dr. Christina Founta, Dr. Olson, Dr. Richard Salter. Thank you all very much indeed on behalf of DySIS and on behalf of the audience. Thank you again.
Goodbye.
Thank you very much. Bye.
Bye.